Good afternoon, everyone, and a very warm welcome to all of you. I'm delighted to greet our participants joining from various places from this exclusive live webinar organized by ONUS Robotic Hospitals. Today's topic is one of the affected millions globally, yet holds immense promise with the modern medicine. We are here to discuss rewiring movement in Parkinson's diseases, a journey of hope, science, and recovery. And today's session focuses on how neurological advancements are helping patients regain movement, balance, and confidence in Parkinson's disease. It gives me great pleasure to introduce our expert speaker, Dr. Tejaswi Rao, Senior Consultant Neurologist and Head of the Neurology Department at ONUS Robotic Hospitals and ONUS Neuro Institute. Our doctor has extensive experience in diagnosing and treating complex neurological disorders, including Parkinson's, stroke, and movement disorders. We are truly honored to have her with us today to shed light on how brain rewiring can transform Parkinson's management. Throughout our session, please feel free to share your questions in the chat box. At the end of the webinar, we will take questions and discuss them directly with the doctor to get her expert insights and recommendations. Doctor, over to you, please.
Thank you so much, sir, for the nice introduction and having me here today. So today we'll be discussing what is Parkinson's disease and how can we rewire those movements which are lost in this disease. So Parkinson's is actually a neurodegenerative. Degenerative means in sense that it are damaging neurons which progressively affect the movement of the body. Because this is involvement of basal ganglia. Basal ganglia is like a movement control center of the brain, which is being affected and degraded over a period of time based on the type of disease within Parkinson's also, and which is why the movement is primarily affected. But as unfortunately, as a well-known thing, this is not the only part associated with Parkinson's disease. There are many things associated along with the movement loss.
Yes.
So where exactly is the loss? So these cells, the neurons which are lost, are actually primarily known to develop or secrete dopamine. The dopamine producing cells. So because they are specifically damaged, that is why it's a dopamine deficiency disease. Why is dopamine very much important? Because it coordinates our muscles and movements. So it is very different from what stroke is. It is the finer movements and the coordination between each and every movement. It's what the main control of the substantia nigra, that is the part of the cell or part of the brain which is responsible for dopamine secretion. So you can see the right side image where we can see the substantia nigra looks like this dense in a normal brain. But when this is narrowed, not only the death of the cell causing narrowing of the tissue, along with the decreased functioning of the remaining cells also. So this is an image which shows how reduced substantia nigra tissue happens in Parkinson's disease. Okay, so next, what are the classical symptoms? So like we discussed, it's a movement disease. So what are the motion related symptoms? What are they? So tremor. Tremor is the shivering, the commonly well-known thing that Parkinson's patients have, tremor. But tremor is a component of a movement. But if we cannot maintain it at rest in a particular posture, that is when the tremor happens, the to and fro motion, which happens involuntary. It can start in one hand and one leg when it comes to typical Parkinson's. But there are other Parkinson's disease where it can happen both sides as well. Next is bradykinesia. Bradykinesia means speed. Brady is slow in the speed. So movements are slow. They are there. They are not paralyzed. All the movements are there, but each and every muscle is moving slowly. It can start from hand movements and leg movements, the chest movements, the lip movements, the eyelid movements, the neck movements. So it is actually everything. That is why the Parkinson's face looks like mask face, as if it's not showing any expressions while we are talking. Only because there is less movement of the facial expression related muscles. Next is rigidity. Rigidity is nothing but stiffness in the body. The rigidity is actually two types. Stroke patients will also have rigidity, but that rigidity is different from this. This is called cogwheel rigidity. That means it looks like a wheel pattern when we are trying to move the hand. It relaxes, resists, relax and resists. Fourth is postural instability. That is nothing but balance, loss of balance and loss of writing reflexes. Writing reflexes is if we are standing or walking on an uneven surface, or we find something coming in our pathways suddenly without knowledge, our body can have a reflex movement to protect ourselves from falling. So this reflex movement is not only slowed down but also over a period of time becomes absent, which is why the tendency of falls in Parkinson's disease increases over a period of time. So these are the classical features of Parkinson's, but along with that, we also have a lot of other systems involved where the mood, the cognition, the understanding, the calculation is affected, the sleep is affected, the smell neurons are also affected, and also the reflex, like we discussed, postural instability. Along with that, there's a lot of other reflex nerves which are affected, which goes to the heart. That is how once we are in a panic state, our heart supply also should increase. Our heartbeat also increases. So if that doesn't work properly in the proper millisecond of the time where we need it, we definitely cannot protect ourselves from falling. These are the classic symptoms, but these are not the only symptoms. So this is just a gross picture of where all the tremor can happen: legs, hands, giddiness, confusion, calculation impairment, mood disorder, and all those things. So, how does a classic Parkinson's patient look? This is how it looks. They look masked. They don't know. They will be actually trying to give expressions. Unfortunately, we cannot see it. And their posture is usually very drooped forward. They'll be walking slowly, talking slowly. They'll have generalized body pains. Their mood will be bad, usually depressed, withdrawn, and they may have associated dystonia. Dystonia means cramps. Cramps which are painful and causing a sustained, that means consistent movement of a particular part of the body, which cannot be voluntarily reversed. So this is what happens in classic Parkinson's, but this is just the basic of it. There are much more than that, which needs further evaluation and will have specific treatments accordingly. So among the Parkinson's, like we discussed, there's a loss of dopamine secreting neurons. So all these above discussed symptoms are commonly dopamine related. So like reduced eye blinking because the facial muscles are low, low volume of speech, also slow speech, and small handwriting because the movement of the fingers will need that dopamine to make the curvature in the writing. When it is low and slow, you will write it slowly. So that these are all dopamine related symptoms. But along with dopamine neurons in the substantia nigra, there are other components of the brain which I'll be showing you further, which are lost, where serotonin and the other acetylcholine is also lost. Neurons associated with them is also lost, which
Yes.
is where the mood, the tremor, the instability, the reflex response, the smell, these are associated with those. So, like we discussed, motor symptoms, non-motor. Motor symptoms are classically movement related, dopamine related. Non-motor is the other things, which are other neurotransmitter related. So, in the microscopic picture, if we see the loss of the substantia nigra as well as decreased functioning of the substantia nigra, this is a part of the brain which stops functioning, will be associated with this will be associated with degenerated neurons there, non-functioning dead cells in simple words. So once the cell is dead, they will not transmit the chemical, the neurochemical which is required to pass the information to the body. This is a normal, the upper picture is normal. The lower picture can clearly show that amount of dopamine is very low. It will also be slowly released.
Yes,
So
sir.
definitely there will be that response shown clinically in the body. So how do we diagnose? Grossly, this is one of the most important and one of the few diseases which are diagnosed primarily by clinical examination only. There is something called UPDRS scaling. It is formed by the Parkinson Society of the World. So we have scores for movement, we have scores for voice, we have scores for mood, we have multiple scores based on which come to a conclusion that patient stands in which category and which stage of the disease, and what can we do best to improve their quality of life. So based on that, we can diagnose. Also, now we are seeing there are early onset Parkinson's before 40, 50 years. There's genetic Parkinson's in families, wherein we can, there are other secondary Parkinson's, which are happening because of the damage of those neurons only, but because of some other things, other reasons. It can be ischemia, it can be stroke, it can be infection of that particular region where Parkinson's also affects. So in this way also they develop Parkinson's symptoms, but it is not classical Parkinson's. Also, they may have a different prognosis. The response to treatment will be different because the cause is different. So most important challenge will be replacing that dopamine, and because we replace it through the body to the body through either tablets or through injections. So this dopamine reaching the brain, crossing this barrier and reaching the brain cells and showing the effectiveness is the challenge, because the one secreting within the brain and the one which we give from outside will obviously will have lot of variability. They will be having side effects. There will be having the bioavailability based on how our gut is, what our food intake is, how do we take the tablet. We're supposed to
Yes.
take the tablet at a particular time of the day, along with the food management between the tablet and the food intake. So there are multiple things which will finally decide how much dopamine we have given and how much actually is working on the patient and how can he come back to his routine lifestyle when it comes to the moment. So there are multiple other tests also where we can pre-diagnose in the prodrome stage, because the degeneration starts very, very early. Until 60 to 80% of neurons are lost, Parkinsonism symptoms are not very evident. So we can actually identify the symptoms in the early stage where 20-30% neurons are lost by symptoms like mood disorders and sleep related behavior change and smell. But unfortunately, 99.9% of the people will ignore these symptoms and label them as a consequence of something else, like a febrile illness or a stress or
Yes.
any
Yes.
financial or family stresses associated, or COVID for that matter, for smell.
Yes.
So
Yes.
people do associate these symptoms with other diseases and ignore in the prodrome stage where actually very few neurons are lost, where actually treatment can benefit them to the maximum. Once it is already degenerate to a certain extent, only then we can identify through the imaging. Clinical, definitely, but imaging also gives an approximate idea that how much neurons are still there and how much dopamine do we have to give the patient. So one of them is we can check the thickness of the optic nerve behind the eye. So we can do the optical imaging. We can do the PET scan. There are multiple scans. I can show you the images how we see. So this is the image of the optic nerve, the thickness of the nerve behind our eye, and we
Yeah.
can uh, address it based on, even though the visual symptoms are not very gross on examination, we can still identify it based on this. So these are the marked, whatever are the colored areas. The blue one is the main dominant area which is damaged initially, but all these red, pink, and orange, green, all these areas are associated with other neurotransmitters that they are also damaged, and these are responsible for these prodrome symptoms.
Okay.
So on microscopic appearance, basically on the biopsy of a Parkinson's patient, we can see that the brain cell will have these depositions. These depositions are actually not supposed to be there. They should be released by the body with the proper sleep. It should be detoxed. But
Oh,
once
yeah.
they keep depositing in the brain, this is why the cells become damaged over a period of time. So this is a basic correlation between how we see a normal MRI, where MRI 99% does not show a Parkinson's related degeneration in that particular area. But if we do a PET scan or a SPECT scan, is iodine uptake neurotransmitter related nucleotide scans, which we have developed to identify the functioning of that particular part of the brain, whether they are secreting it or not. Where an MRI just shows the structural part. How is it? Is it there or not? Is there a lesion or not? But we are looking more in terms of functionality of the brain, which is why perfusion scans are more related. So this is an F-DOPA PET. It's a fluoride, there's a nucleotide uptake related, dopamine related scan. So on the right side is a normal dopamine uptake in a normal patient. You can see in a Parkinson's patient, even prior to symptoms, the dopamine uptake is very less. So this is a TODAT SPECT scan. This is also a neuronucleoisotope, which we give through the blood so that we can identify the amount of, this is the stages from upper to lower. This is a most severely damaged substantia nigra with minimal to minimal dopamine secretion present in the brain. So this can give us an approximate idea not only for diagnosis but also the response to the treatment.
Okay.
It's the same thing. Serotonin. Serotonin is one of the other neurotransmitters which we were discussing. The red colored is a normal level of serotonin supposed to be there in the human body. But as you see, even before the symptoms arise, serotonin levels in the brain, uptake in the brain has come down. So even before the symptoms, we can identify the early onset or early stages of Parkinson's. Once the symptoms have arisen already, you can see the red is hardly visible. So in this stage, the treatment, no matter how much we try, the response to treatment cannot go back to a healthy human because of the drastically affected neurons. So how do we treat it? There are few mechanisms. There are multiple. Levodopa is nothing but dopamine. We give it directly with a combination of a medicine, and there are other medicines which can, instead of giving a dopamine directly, we can increase the functioning of the already secreting dopamine. So, which is why it is important to know how low the neurons are, because we can always supplement giving dopamine from increasing the already dopamine functioning in the brain. So, which we can go for initial stages of treatment, and once that level of dopamine is absolutely down, that is when we can think of giving more and more dopamine itself from outside. So, this is
Yes,
how the treatment also depends a lot on the symptoms and imaging, not the regular MRI imaging, but the nucleoside imaging, which most of the people do not know. And last but not the least, we have come up with something called deep brain stimulation. Why deep? Because substantia nigra is very deep into the brain. So, brain stimulation, what are we doing? Instead of giving drugs to increase the already secreting dopamine neuron, we can stimulate it through an electric current and make it work further. You just give it spark and give it more energy and petrol so that it functions faster and more aggressive. So that is what in grossly devious does. But it is a surgical procedure. It is an open procedure. It involves a lot of expertise and lot of monitoring.
yes,
And we
yes,
do decide whether the patient is really fit for it or not. And
yes, doc-
does he really need it or not? Not every patient, not every early stage patients will need DPS. It's very selective, very individualized, associated with his comorbidities also. So this is good thing that we have an option even in the late stage. So it is not just going to be the tablets and DBS. It also we have to include physiotherapy, speech therapy, the
yes,
chest therapy to prevent, because the movement of muscles to the lung also go down. So the breathing also affects the motion, the movement, the swallowing, everything gets affected. So we do need a proper rehab team along with the neurologist to help the patient and
yes,
monitor their response with the tablet so that we can, develop ourselves and give the tablet according to the patient needs and the patient time of need as well.
yes,
So
exactly.
there are further beyond DBS also, we have a lot of other techniques nowadays, which is nothing but cell replacement therapy. We can take it from an embryo, we can take it from a fetal, we can develop ourselves through a stem cell as well. Other than that, this is nothing but bringing it from outside and implanting it there. There is another method like neurotropic factor. We give a growing kind of a factor into the brain where it itself can produce new dopamine secreting hormones. These are all high-end technology and needs a lot of expertise, and multidisciplinary team of doctors needs to be involved for a particular a hybrid treatment to happen for a particular patient. That
Yes,
also depends on the stage where the patient is in the first place. So stages like I discussed, the level of the neuron, the number of neurons, and the functioning will determine at what stage the patient is. So this is the movement graph. We can see graph 0, 1, 2, 3, 4. The movement will reduce drastically. The amplitude of each and every muscle movement will decrease drastically and very gradually. And unfortunately, very few people will identify that difference in the early stages.
yes, yes, doctor.
And we are looking for other methods to identify Parkinson's in the prodrome phase, other than relying on patients' identification methods. We're looking for other methods or tests to identify it. Well, we are into it. Let's see what we can come up with. And so Parkinson's is actually a marathon. It is not sprint. It's going to be a long-term process, and It's what the future is, and we do have a lot of options. They are still in process. Some are working great, some are giving us great results. And we should always remember that the disease is progressive. The treatment that is given today is not going to be enough tomorrow. It is
Yes, yes,
always going to be progressive. So the treatment also will be changed according to the disease. This is one of those diseases where one tablet today will not be enough tomorrow.
yes,
So we
yes,
should keep
exactly.
that in mind, and not just the patient, but also their caregivers needs to be given mental education about how the patient reacts and what kind of treatment or care can we do or give to the patient along with the tablets. Okay.
Exactly, doctor.
So Parkinson's disease we should always recognize as early as possible so that we can give treatment to rewire and reconfigure the brain functioning. So thank you.
Yeah, yeah. Thank you so much, doctor, for such a detailed and inspiring talk. Your insight into brain plasticity, rehabilitation, and modern neurological therapies truly give new hope to patients and families dealing with Parkinson's. Doctor, here we had some sample questions from our viewers, so we'll go for that.
Sure.
Yes, doctor. Doctor, question number one, that can Parkinson's symptoms be reversed with therapy?
Like we discussed,
Yes.
it is not going to be reversed. It can be managed for that particular time period. It almost looks like a reversal, but it is not really reversal. It is managed because we are replacing the dopamine lost in the brain with the medicines. So we can replace as much as possible, but there is a limit to everything. So once the disease progresses beyond the replacement doses which we can give, that is when it will progress beyond reversal.
Yeah, that's fine, doctor. And next one is that what lifestyle modifications help improve daily functioning, doctor?
Daily functioning, if you're already a Parkinson's disease, you should just make sure that the rest of the brain, like I discussed, other neurotransmitters, brain is a one thing which needs more challenging to function better, not rest. So keep challenging your brain, have a healthy diet, and add lots of nuts and omega 3 in your diet so that at least the growth, because neuroplasticity is something which is a beautiful thing that the brain has. It can adapt to whatever is lost in the body. I mean, the body functioning through the brain. So if we give that hope and give that pressure as well as the support to the rest of the brain, which is normal, the brain itself will adjust and modify itself. That is why it's called neuroplasticity, to adapt to what we can do for us daily living management. After that, that is when we need to give the treatment to the patient.
Yeah, that's fine, doctor. Yeah, next one is that is robotic or AI based rehabilitation effective for long term recovery?
Yes. I mean, if you are decreasing the human effort, because anyways, robot is more precise
Yeah.
and more efficient when it comes to that matter, because the weight of the patient, robot does not have to think about his capacity of lifting the patient and helping him stand or walk. So yes, any physiotherapy for that matter, any robotic and AI associated will be helpful for the patient, not just for movement but also for enhancing the movement of lips, face, the throat, the swallowing, everything. Everything can be helped. The speech therapy, the chest therapy, everything can be helped with AI along with the medicines. And like we discussed, DBS is one of the
Yes,
technical
yes.
things. DBS also has a lot of role of AI in it. Along with the doctor and precision, the decision along with the UPDRS scoring, we do involve a lot of technology into it for precision and minimal, what do you say, scarring which we can cause, so that we
Yes.
are only going to do or touch the neurons which are already damaged rather than doing any other parallel side effects during that procedure. So yes, AI does a huge help when it comes to Parkinson's disease.
Yeah, that's great, doctor. Doctor, next one, that can stress or sleep affect Parkinson's symptoms?
Sorry, I didn't get that.
Yeah, can stress or sleep affect Parkinson symptoms? Like if you
Stress
sleep?
or sleep?
Yes,
Okay.
yes, exactly.
Yes, I mean stress will cause you release of more of a bad hormone when it comes to good hormones which are needed for the body. Dopamine is going to go much less if you're already in stressful. It will increase all those cortisol, which will unnecessarily increase your sugars and cholesterol. That is
Yes.
one thing. And
Yeah.
secondly, to stress, you're not going to sleep well. And
Yeah.
sleep is very vital to detox your brain. So brain is already degenerating for whatever reasons. If you're
Yeah.
not sleeping properly, definitely it's going to add on to it. Definitely going to add on. To what extent depends on how bad your lifestyle is.
Yeah. It's really great point, doctor. Doctor, last but not least, at what stage should one consult a neurologist if tremors or stiffness begin?
As early as possible. If you notice a tremor and if anybody in your family also has a tremor, as soon as possible you should refer to them because there is no time or age limit nowadays. Earlier it used to be only elderly used to get Parkinson's and things like that. But I would say unfortunately that we are noticing it in young as well. And there are a
Yes.
lot of genetic diseases associated with them. So the
Yes.
earlier the better, as soon as possible. It's better to rule it out than being sorry later.
Yes. Yes, sir. Yeah, doctor. Thank you once again, doctor, for sharing such valuable information and bringing clarity to an important neurologist condition. Thank you so much. To all our attendees, thank you for being a part of this live webinar. We hope today's session helped you understand that Parkinson's is not the end of the motion, but the beginning of mindful movement. Really great. Really great show, doctor. Thank you so much once again. This is your host, Sai Kiran Tej, signing off. Stay safe, stay healthy, and stay good.